All right, we'll go ahead and get started just to keep us on time. Thank you all for waking up early to hear about some street medicine. Hopefully it'll be worth your early wake up. I think it will. We don't have any disclosures. So we have 4 different institutions who are at various stages of implementing street medicine in their cities. And so I want to kind of tell you about some of the ways that we're doing that, some of the challenges that we face, some of the strengths of the different programs, how we incorporate trainees, residents, and medical students, and how we engage with our local community partners. So those are going to be our objectives for today. Again, because you're here, I assume you probably know some about street medicine and the importance of it, but just in case, want to start with a little bit of background. So there are over 650,000 people experiencing homelessness on a nightly basis in the United States. And people experiencing homelessness experience higher disease burdens, higher rates of disease, and die on average 30 years or 3 decades earlier than their housed peers, most commonly due to preventable and treatable chronic medical conditions. Meanwhile, the healthcare utilization cost for this population is more than 5 times the national average. So I think this really shows us that the mainstream healthcare delivery model is failing to meet the needs of this complex and vulnerable population. So that's where street medicine comes in. Street medicine's goal, or definition of street medicine, is health and social services developed specifically to address the unique needs and circumstances of unsheltered homeless delivered directly to them and in their own environment. So we have 20 minutes today, but we could talk on this for 20 hours. So this is a handout, again, kind of diving more deeply into the 4 different models that for the institutions we have here. You'll get to hear briefly from each institution, but if you want to learn more, or this has our contact information as well, please visit this, and we'll have this at the end as well. So we'll let everybody introduce themselves, but I'm Erin Shuffleberger. I'm an assistant professor at University of Alabama at Birmingham, and I serve as a co-faculty advisor for our street medicine clinic, which we've had going for about a year. So if everybody wants to start, just kind of go down the line, introduce yourself, tell us where you're practicing, and talk a little bit about your street medicine model.
Hi, my name is Haneen. I'm a rising 4th-year medical student at Mayo Clinic, Alex School of Medicine in Rochester, Minnesota. So our population is the city is about 120,000 people, and in that population, our unhoused population is very small, and that kind of shapes our program to be less structured and smaller than the urban centers that you'll be hearing from. Our program initially started back in 2020, and it initially started with Zumbro Valley Medical Center, and their initial project was basically teaching the community about the unhoused population through online programs. Since then, though, it's expanded to include a selective program that involves our school, multiple free specialty clinics, including ophthalmology and dermatology, and then we do street runs as well, but they're smaller in scale in terms of 1 physician, 1 social worker, and then volunteers, including students and residents. And then there's multiple collaborations that happen throughout the year with the local organizations. A unique aspect of our program is the involvement of people that have direct lived experiences. CVMS has started a program called The Table. It literally stands for a team of advisors who have lived experiences, and they help direct the program and give direct input on the policies and the programming that we kind of form. In addition to the fact that we have a smaller unhoused population to serve, we also have a city ordinance that recently banned tenting, so that's made it even more difficult for us to access the populations that usually would be centralized or congregated, and that again leads to the fact that we don't have as structured of a program. But the fact that it's small also leads to us being able to respond to needs faster. An example of this is a new pilot program that they've launched called Recuperative Care, in which patients or unhoused community members who are undergoing a medical procedure or who have undergone a medical procedure can have a safe place to heal or prepare for their procedures.
My name is Christine Shaw. I'm a 2nd-year Global and Social Emergency Medicine Fellow at the University of Alabama in Birmingham. So our free clinic, we are a subset of our Equal Access Birmingham, which is the student-run free clinic through the medical school at UAB. So for the past 10 years, they've already had a twice-a-week brick and mortar clinic that provides free health care for our underserved populations. But we found especially people experiencing homelessness have a hard time getting to these brick and mortar clinics. And so this past year, about February 2024, we started our street medicine clinic that Dr. Scheffelbarger and myself are the co-medical directors of. So we are partnered with an organizing body called Be a Blessing Birmingham that coordinates multiple different agencies that come out. So we meet once a month in a park and provide basically, at this point, convenience care. So there's, in addition to our tent, there is a clothing shelter that's there, a church that provides food station, and then we have a recovery resource center that is there providing education for substance use, connection to resources, and things like Narcan. So it is a student-run free clinic. So it is organized by the medical students. We have a board of executives for them that come in and organize, and then the volunteers. So just like your standard student-run free clinic, the students do the H&Ps and present to the attendings. They come up with the plan and say it's allowed us to be very flexible, but we get to select. We carry like one backpack full of medications. So because of our limitations in street medicine, we do a lot of acute care. And our population that stays around that park area are a large collection of people with that use IV drugs. So we do a lot of wound care, treat a lot of abscesses and things like that. So our goal is to hopefully continue to expand both in locations and scope, but and say that has been our general structure so far.
My name's Chase Palish. I'm with the Vanderbilt Homeless Health Service, which started in earnest 2 years ago. We launched. We began with a question of, everyone who's in emergency medicine treats patients who are experiencing homelessness. We just didn't know what the scope of that problem was. So we began a screen for everyone who came through the ED. So every single person gets screened for housing instability, and that allowed us to recognize 5% of every patient encounter is a person who's experiencing homelessness. It was over 1,700 unique individuals a year. Nashville has a population of about 2,000 people who are experiencing homelessness. So out of that, the question was what to do, and so we started a hospital-based system. So we have 2 community health workers, a social worker, and 2 physicians who, together we can see patients in the emergency department. We get consulted from our ambulatory setting as well as our inpatient setting. We can meet the patients where they're at while they're in the hospital, but then we weekly go out on street rounds to see the patients who've been discharged in an effort to try to continue their care plans, which often, as everyone knows, become very fragmented. And the goal isn't necessarily to keep them out of the ED. The goal is to try to help them, continue the care plan in the most beneficial way to the patient that's possible. So a lot of times that does end in them coming back to the emergency department for one reason or another. And then probably one of the more important things that we've been able to do is partner with 2 community partners who actually go out with us and are able, through a specific process called SOAR, help our patients apply for Social Security insurance, Medicaid, Medicare, and receive housing, navigation, and assistance. And that probably, in the long run, the housing is the healthcare, and so those are probably the efforts that are actually improving our patients' lives the most.
Hi, I'm Kat Weaver. I am the medical director of UCLA Health Homeless Healthcare Collaborative. Los Angeles County has a very large homeless population. As of the 2024 count, the county had 75,000 estimated, with about 70% of them experiencing unsheltered homelessness. Los Angeles County is huge. We don't cover the whole county, but we do cover 4 of the service planning areas, and the population of that is around like 40 some odd thousand. We are also one of well over 20 street medicine teams in Los Angeles right now. So we launched because, based on UCLA Health data, 85% or so of ED visits from people experiencing homelessness was due to conditions that could easily be either treated or prevented in a community-based setting. And only about 15% really needed the specialty care or admissions. So we initially launched with a model of identifying that despite we have all these street medicine teams, there's like no way we're gonna come close to being able to to contact every person experiencing homelessness. So started with more of an episodic care model and the transitional primary care model. We are staffed by attending physicians, APPs, all on a part-time basis, like even I'm 75% time, who are also faculty in the departments of emergency, family, and internal medicine. And we have community health workers, nurses, social workers. I'm probably leaving someone else out, but and we launched in January of 2022. Started with 2 mobile units right there, and we now just got our 6th one. So we've grown a lot in our 3+ years. We are able to dispense medications, prescription medications directly from the vans. We are able to do point-of-care labs, working on doing a more robust lab collecting. And we also we now have psychiatrists as well. So we have there are a lot of change. Even our 6th one has like has a chair, an actual exam chair. So we're going to start focusing on women's health perinatal care as well.
Awesome, thank you. Can a couple of you touch on kind of how you incorporate students and residents, kind of medical trainees, into your clinic models?
So for our program, the main involvement for students is through a volunteering basis, and that's mainly through the selective, the street medicine selective. So our curriculum allows for they have 1 week between blocks or like longitudinal programs for students to engage in like enrichment, and one of those available programs is street medicine. There's a high interest rate, so about 90% of each class in the first year joins the street medicine program. This includes about 4 workshops such as like trauma-informed care, women's health care, and naloxone training, for instance. Each year it's different. Once they go through those training programs, then they're able to volunteer. So they do they do on the street runs, they volunteer at the free clinics, and they help come up with the ideas. So most of the ideas are coming from students each year, including the most recent one being trying to address like the pediatric aspect. So there's a involvement with the youth shelter in Rochester. And then the opportunity for residents also comes through a volunteering basis, mostly at the specialty clinics. So like they'll come and help on the runs as well.
So as I had said, our clinic is the student-run free clinic, so it was very much student-driven. I came in starting my fellowship saying, hey, I want to start this as a project doing street medicine, and actually the students came and found Dr. Schuffelbarger and I said, I would say, here, perfect, here are my notes of structures of things that I had done based on what I did in residency. So we very quickly were able to get it organized, establish some protocols based on a project I had done previously. And kind of modeling, like I said, modeling the Equal Access Birmingham that we already have, the student structure. So there's the student executive board that organizes the supplies, the resources, the times, and then the medical student volunteers. So they see the patients, they do the H&Ps, they come up with a plan. I think one of the biggest shifts we did in from moving from the clinic to the street is in the clinic they had the different stations of one student was in charge of like taking vitals and doing the intake, and then there's a different H&P team, and having kind of you switching roles throughout. And I remember as a med student where I went, we had the same kind of thing. You signed up to be an intake, you signed up to be phlebotomy, you signed up to be an H&P-er. That structure of passing patients off didn't work as well in street medicine, and so now the students pair up and they take a patient from when they check in until when we discharge them. It allows them to get that good whole picture. It gets them to have a better relationship with the patient, and then come up with a plan and say, like I said, we've got basically a backpack of medications. Every once in a while, if it's something that's reasonable but we just don't carry, I can call in a prescription and get them to a pharmacy that they can afford it at. But yeah, and say our students do a lot, and really get to see the whole picture of the barriers that this patient population faces. So it's a really good learning environment with them. And then the same way that in clinic we do hands-on clinical learning as well, we do a lot of teaching pearls and stuff and helping them build their differentials, even though we're at a street medicine clinic.
I found our medical students to be incredible advocates for our organization. So as you start up a new organization, first there's enthusiasm, and then there's a lot of hesitance, and then people from legal and compliance are calling you, and then you have to deal with that. And so the medical students are really a voice for change in our institution. They are definitely at the bleeding edge of trying to push the institution forward. They formed a street medicine interest group of their own accord that we help oversee. They've run vaccination clinics. They run monthly wound care clinics. They volunteer with us. And then they've actually, again, of their own accord, helped lobby the dean of the medical school to help us create curriculum for an advanced elective to be able to go on in a more systematic and thoughtful way on the street. We, again, legal and compliance, have had a lot of issues with, so far, just as a startup, getting them to do something as involved as what you're hearing about at UAB. So hopefully through the advanced elective, now we can incorporate them more fully and less on like a volunteer basis and more into a real like clinical education setting. Although the exposure itself is very valuable, and I, again, just can't emphasize enough how valuable they've been to pushing our institution to support us more than they probably would have otherwise.
All right, we have a couple minutes left. If you could talk about at Vandy and UCLA, like a strength and or a challenge that you faced in your street medicine journey.
Yeah, I already started on some of the challenges. I think incorporating into a health system, you start to really rub against sort of the business of medicine, which maybe in a deep red state without Medicaid expansion is not something my organization was, from a financial perspective, really looking forward to. However, I think you really can be the exposure piece there to show where you are making savings, why this does matter. And so, yeah, definitely one of the long-standing challenges we're going to have moving forward is financial sustainability, because we do, as part of the healthcare system, have to keep our bottom line afloat due to, especially in the current setting where many health systems are making cuts, there's not a lot of money to go around to efforts like this at the moment. And so certainly funding is something that's most top of mind for us.
Yeah, one of our strengths is that we are backed by a big health system, not monetarily yet, but it definitely helps to have the support of the health system, of like the UC chancellor, and also that a bunch of our faculty is embedded elsewhere in the system. So we have a bunch of hospitalists, emergency medicine, so we have allies, and to be able to advocate for our patients and build systems. Similar to what Chase said, funding is always going to be the biggest challenge. We are lucky in California that historically our Medicaid has been more robust. Although even just yesterday, our governor came out and said that while we used to provide Medi-Cal for people without documentation, that there apparently are going to be limitations to this. There's also California it's now doing billing for street medicine is now something that you can do in any of the states. California was the first to recognize the place of service code and to start trying to put in infrastructure to bill for street medicine. Similarly, there's a program called ECM, Enhanced Care Management, that any assigned Medi-Cal patient can have access to based on certain criteria for basically increased case management. So we're getting paid to do case management as well. But then actually making this happen, negotiating with the different insurance has taken like almost 2 years at this point. So still challenges there.
Awesome. I think our time is almost up. So I hope this is just the start of the conversation. Again, our contact information is here. Please reach out. Sorry we didn't have more time for questions, but we'll be in the back of the room too if you want to, if you have questions that we can help answer. And then our email addresses are here. So excited to talk further.